Harendra Kure. I'm the emergency physician at the Neurotrauma Center National Hospital. I'm going to spend another half an hour with you, trying to take you through an approach to a seriously ill child. It's absolutely important that all you young doctors waiting so impatiently to get to work, put your entire knowledge base into a very systematic approach when you're dealing with emergencies, right? So that's basically what I'm going to try to do for you. Try to focus on what is important when you're managing a seriously injured child. So like everything else, the approach has to be simple, something that you can remember when you are in front of you is a seriously injured child. So it should not be complex and complicated. The approach has to be easily remembered. You need to kind of practice it in each and every encounter that you face in your exciting medical career that you're about to embark on. Okay, so the learning outcomes is going to be the structured approach to a seriously injured child, how you identify what are called life-threatening injuries, and how do you assess and fix the problem. So basically initial stabilization and resuscitation. So like all good things, we're going to start with a case-based scenario, which is the most effective kind of form of teaching emergencies to the medical professionals, be it young interns like you to postgraduates or even senior consultants sometimes, nursing officers, our support staff. So very easy to do a case-based discussion and treat and kind of learn how the approach is. So this is a common scenario that I'm sure you're going to encounter in the future, in the very near future, actually. So here's a 13-year-old young naughty child climbing up a tree while the mom has gone out shopping. Of course, in this day and age of lockdowns, this won't be happening that commonly, but anyway. And he falls down from the tree onto a low garden wall and then onto the footpath. So he falls from a height of, say, about 6 feet, and he cannot stand up. And when the mother comes home, she finds him lying on the ground, and she calls 1990. Okay, so that's the kind of mechanism of injury and the scenario that we're going to take forward in our learning objective. Right. So now, it is absolutely important that you grasp this simple concept when you're managing emergencies, be it a trauma, be it any other emergency. The approach has to be very systematic. And the important aspect is assessment, which has to be very objective. And you need to have a goal when you're assessing your patient, right? It should not be haphazard. It's not like shooting in the dark. You have to do something, you have to do it systematically, so therefore it becomes very efficient. You don't take a lot of time. You do it in a sequence. And you have to have some goal as to what you want to find out, because when you find out something, you find out whether that is normal, abnormal, or whether it is immediately life-threatening, and then you need to fix the problem before you carry on with the rest of your assessment. So in trauma, the first and foremost thing that you need to do is look for what is called catastrophic external hemorrhage. And as the name suggests, what you mean by external hemorrhage is something that is very obvious to your naked eye. So something that you will see where the blood seems to be gushing out from some injured part of the body. So you need to control that. That is absolutely paramount when you're managing a trauma. And whether it be pediatric or adult, it is the same thing. So the first thing that you look for is you scan the patient as the patient comes in front of you to look for any catastrophic external hemorrhage. And the adjective here, catastrophic, means that, you know, the bleeding can be so rapid and fast that it's going to compromise the intravascular compartment very fast. So if you don't control it and stop it, you might actually end up with a mortality. Okay, so that is the important things. That is why you have to address it first. Second, of course, is the airway. And what are the things that we need to assess in the airway? Okay. So what we need to know is this airway patent? Is it open so that it can conduct the atmospheric air down to the lungs? So you need to have some form of finding out, is this airway patent? And the most simplest thing to do is to try and get the patient to speak to you, so you can ask a simple question. That patient is able to produce a sound and get an answer to you. If that happens, then you know there are so many things that are assessed in that simple process of asking a question and getting an approach. Sound, and also that the higher mental functions are also in order, because I just got a notice saying my internet connection is unstable. I just hope that this is not getting garbled. Anyhow, that just tells you that the patient's level of consciousness is quite appropriate, because they are able to answer the question that you have asked. So that in itself is an assessment of the airway's ability to be patent, and also if they are conscious enough, they are able to protect the airway. So airway patency and protection is what you are assessing in A. Okay. And if it is a trauma, especially a fall from a height, you have to be paranoid about the possibility of an unstable cervical spine injury. Okay. So to make an unstable cervical spine injury stable, you need to ensure that you do not allow the patient to move the neck. And what I mean by move the neck is flexion, extension, and rotation at the cervical spine. So you can use simple methods such as sandbags and immobilize or limit the mobility of the neck, or you can use a soft collar. So whatever you do, you try to find some way of limiting the cervical spine mobility, right? That is absolutely important. Then the third important thing that you're going to assess is the breathing. And when I say breathing, what I mean is the patient's ability to perform this simple but life sustaining function. Okay, that is to take a breath in and then take and to breathe out. So breathe in and breathe out. Okay, so you are going to assess this objectively. How do you assess the breathing aspect of a patient or a child in this context? It is a objective assessment of the respiratory rate. Absolutely essential that you keep your palm on the abdomen of the patient and count how many times it moves up and down for a full minute. And that will give you the most objective assessment of the respiratory rate. Okay, that is the only correct way to measure a patient's respiratory rate. The next thing you need to do is, and I'm sure everybody is so very familiar with the pulse oximeter, because it's kind of a gadget that is in vogue. Every Tom, Dick, and Harry now knows what a pulse oximeter is with the current COVID pandemic. So pulse oximetry is available everywhere now, even in people's homes. Okay, so you just put on the pulse oximeter probe and you find an objective assessment of the percent saturation of hemoglobin. Okay, so that is the second objective assessment in breathing. And finally, you can have a quick look, listen, and a feel even if you want to. So you need the stethoscope. You need to listen to the lungs and look for air entry, whether it is equal on both sides. And if you can hear any added sounds, such as conducted sounds, crepitations, or wheezing. Okay, you can listen to that. And then if you're going to have a feel, you will feel most likely is to do a palpation or then a percussion, really, in the sense of respiratory system assessment. So it's not really palpation, where you can palpate to look for things like tenderness of the ribs, because this is a fall from a height. You can have rib fractures. You can palpate for crepitus. You can palpate for subcutaneous emphysema. But it's really the percussion node that you're interested in. So you will percuss on both sides of the hemithoraces to look for any dullness, to look for hyperresonance. And all of these will give you important assessment parameters to determine if this patient has anything going on which is going to compromise his breathing. Okay. Then we come to circulation. And in the circulatory assessment, it has to be, again, very objective. So there are three parameters that you can do objectively. Number one is to count the pulse rate. Okay. Number 2 is to record a blood pressure. Number 3 is to look for peripheral perfusion in the form of a capillary refill time. And I'm sure many of you must be aware how you do this. If you do not know, this is a skill that we can teach you when you come to us or in your clinical training assessment. Right? If you are in an emergency department setting, you are bound to have a multi-para monitor available, so you can hook the patient to the ECG to analyze the ECG or the electrical activity of the heart. Okay, so these are your assessments, objective assessment in the circulation. And then finally, D or disability is an objective assessment of the level of consciousness of your patient. And you can use two simple scoring methods. One is the AVPU, or where the acronym stands for A is for alert. If your patient is quite conscious and is responding to you appropriately, then you can make this assessment to be an A. If it is only to your verbal commands that the patient responds, it becomes a B. And if it is only to pain that the patient makes some response, then it is P. And if the patient is absolutely unresponsive, even to the most painful stimulus that you can instill on the patient, then that becomes a U or an unresponsiveness. The Glasgow Coma Scale was developed primarily to assess the conscious level in the most objective way in trauma patients. And it is a little complicated, but you assess 3 parameters, and that is the patient's eye opening or the eye response, the patient's verbal response, and the patient's motor response. And it is assessed in different categories. So for eye, you have a maximum score of 4. For the verbal response, you have a maximum score of 5. And for a motor response, you have a maximum score of 6. And I cannot kind of dwell into the details of the GCS, but I'm sure this is something that all of you have studied and learned in your medical career, schooling career. So it is time to put it into practice as you become junior doctors. And as time goes by, I'm sure you will become very proficient in assessing conscious level using the Glasgow Coma Scale. The next important objective assessment in disability is to see what the size of the pupils are on both sides, see that whether they are equal in size, and see what their reaction is to light. So pupillary size and pupillary reaction to light. So all of these things give you kind of a very objective assessment of the level of consciousness, and also an inclination of whether there could be an underlying traumatic brain injury, especially if you find that the conscious level is less than 13, or there is inequality in the pupils, right? This will give you a prompt to consider that this patient may be harboring a very serious condition in his brain. Okay, right. So moving on. So this is, as you can realize, I spent a fair amount of time on this slide, but this is really the crux of the matter, really. This is what basically you have to be looking for. Okay, so assessment alone is not adequate, because remember, when we are managing emergencies, we have to be very efficient. We have to consider time to be patients or resuscitating patients who have got fairly significant life-threatening conditions. So trauma is one such thing. Right. So if you see catastrophic bleeding, the simple, quickest, most appropriate thing to do is to apply pressure, or to, if it is a limb, you can apply a tourniquet. And if it is something that you think you can immediately put a suture, such as a gaping wound in the scalp, which is profusely bleeding, you should do that. Okay, so you assess it, you find there is catastrophic bleeding, and you fix the problem immediately then and there. Very simple things that you can do very efficiently, quickly. The important thing is to remember to do it. Okay, you need to do it then and there. Okay, in the airway, if you do find in your assessment that the airway is obstructed, there are simple airway maneuvers called the triple maneuver that you can do. But remember, if you're managing a trauma victim, you have to always be concerned about a cervical spine injury. So out of the triple maneuver, you can only do what is called the jaw thrust, because you cannot create more movement at the chin lift is something that you will avoid, but a jaw thrust will be minimal movement at the cervical spine. Then in the department that you are assessing your patient, in the resus area, be it the emergency department, you will have certain airway adjuncts. So adjuncts will help you to initiate and create patency in an obstructed airway. Simple things such as the Godel's airway, the nasopharyngeal airway. So these are simple things that you can use. If you find that there are secretions which are pooling or there's blood in the oropharynx, you can always suction it out using a suction device. And what we use standard practice is what is called the Young-Pu suction device, which is a plastic with a characteristic kind of design which helps you to suck out secretion safely from the oropharynx. And then, of course, once you've created a patent and unobstructed airway, you always put on a face mask and turn on the oxygen. So this is what you do when in your airway assessment and in your management if you do detect some issues in the assessment. When it comes to breathing, there are certain complex things that you can do, but there are always simple things that you do first. If you find that the breathing is affected, you might want to use the bag valve mask resuscitator, or we all know it as the ambu bag, right? Where you can assist a patient's breathing with gentle breaths. Okay, once you have created a patent airway, you can then you can actually assist breathing using this device. But if you want to make more sophisticated, so more complex way of supporting the breathing, then you can think of non-invasive ventilation, or you might have to consider intubating your patient and then providing with invasive positive pressure ventilation, right? So this all comes in your breathing aspect in your treatment. When it comes to circulation, after assessing your circulatory parameters, you might want to, that is the time that you gain intravenous access. And remember, in trauma, you need to approach this very early on in your management. And generally, what we say is we need at least 2 intravenous cannulae in the large antecubital veins. And the larger the cannula size, the better it is that you can use, and you can resuscitate fluid faster. And especially if you need to give blood, you need good IV access on your patient. Okay, so tranexamic acid is what is an antifibrinolytic agent, which is found to be evidence-based, to be an absolutely important management practice of using this agent called tranexamic acid. What it does is it prevents fibrin clot breakdown. So in large capillary beds where there is bleeding, this plays a major role in reducing the ongoing hemorrhage. Okay, so tranexamic acid is something that you should be aware of. So, and how you dose it and so on and so forth, you can learn about later. Okay. And if you find catastrophic bleeding, and if you find that your patient is absolutely unstable hemodynamically, and it is a patient who was subject to trauma with a very dangerous mechanism or with a high impact velocity, you must always start resuscitating this patient with blood, because hemorrhagic shock is the most likely cause for their hemodynamic instability. So it is blood and blood products alone that you should start resuscitating these patients if you suspect a concealed hemorrhage, or if you can see it with your own eyes that there is catastrophic hemorrhage. You need to replace blood with blood. That is one of the important tenets in management of trauma patients in the early stages of resuscitation. And this is something that is going to drive down the mortality or morbidity in trauma victims. Remember that very, very well, that when you are suspecting hemorrhagic shock, you have to replace blood with blood. So the earliest blood product that you can get from your blood bank is O negative blood. And then once the cross match is complete, you can get group specific cross-match blood, but you can always start with O negative. Until the blood arrives, you can always use crystalloids in the form of normal saline with a dose of 10 ml per kilogram as a bolus. And what is meant by a bolus is give it as fast as you can, depending on what kind of IV access you have achieved. Okay, never forget the management of pain in trauma, and the go-to or the gold standard of analgesics in trauma is intravenous morphine. And the dose is 0.1 milligram per kilogram, and it is the same for pediatrics and for adult. So you have to give adequate pain relief, especially in trauma. Right. So here are certain little, a few images that I'm going to put up on the screens. Unfortunately, one of the drawbacks in these Zoom-based discussions is that I don't get to hear any feedback. But what I'm going to do is kind of keep a few seconds or a few seconds of the image so that you can kind of have a look at it. So this is a child with, as you can see, he's got a nasal prong delivering oxygen. So obviously his breathing has got compromised, but this is abrasion over the neck. So what are the things that you should go cross your mind? What kind of problems do you think this little child might have? Okay, so it's already come up. Yeah, I will answer your questions at the end, okay? Yeah, so this is what is called a dynamic airway, where we are anticipating airway compromise due to laryngeal edema. So children who are exposed to burns or bruising over the anterior aspect of the neck, you should have to have a very low threshold to electively intubate these patients, because once the airway narrowing paramount importance. Okay, what you see down below is a chest X-ray, which actually, if you are an emergency doctor, you should not actually be diagnosing this on a chest X-ray, but this should be a clinical diagnosis. So it's kind of obvious what it is, isn't it? Okay, yep. So let's get this, okay. Yeah, so this is a tension pneumothorax involving the right hemithorax. You can see there's a shifting of the cardiac shadow to the opposite side, and there's hyperlucency, and there's absent lung markings on the right side. So this is a tension pneumothorax. And what is meant by a tension pneumothorax, and as opposed to a simple pneumothorax, is that there is a drop in the cardiac output because of the pressure effect on the great vessels that is impeding the return of blood into the right heart. So this is a classic example of obstructive, inflow obstructive shock. That is a tension pneumothorax, okay? And if you do detect this clinically, you need to get a decompression done as early as possible. There are two options. Either you can do a finger thoracostomy and relieve the tension immediately. You can also go for a needle thoracocentesis, which was the old practice, but in emergency departments, we practice a finger thoracostomy immediately, and then you follow it up with a IC tube or an intercostal drainage device that you can then insert, okay? And this reverses both the shock and the breathing compromise, okay? Right, next, okay? So here you can see that there is a complete kind of whiteout on the left hemithorax. So what are the possibilities that should cross your mind, especially if this is a trauma patient? Well, I hope this came to mind. Yes, it is a massive hemothorax. And always in trauma, if you find that the pleural space is occupied by any kind of fluid, it has to be blood until proven otherwise. So if this is a trauma victim, you are going to treat this as a massive hemothorax. And the management is fluid resuscitation, because the patient would have lost a fair amount of blood into the pleural cavity. You might want to consider early blood transfusion as well, but you confirm this with the IC tube insertion, and you will find that there'll be a certain amount of fresh blood or altered blood that keeps draining out of the IC tube that confirms that this is a hemothorax, okay? Right, what about this? So you can see an open wound on the chest wall, and it has got a characteristic dressing, which is what we see very observant that you may be. You can see that it's been plastered only on 3 sides with one free side open. And this is what is called a open pneumothorax. Okay, so there is a communication from the exterior through the chest wall to the pleural cavity. So when a patient takes a breath in, instead of the air going through the oropharynx and down the airways, because there's less resistance from the wound, there's air that gets sucked into this wound, and that will cause a worsening of the pneumothorax, right? And then when the patient breathes out, that air just gets trapped, and with each breath, the pneumothorax, open pneumothorax, can become a tension pneumothorax. So that is why you apply this characteristic plaster, because when the patient takes a breath in, the covering will seal the wound, so there won't be any air that goes in through this wound. But when you breathe out, it will flap, the flap effect or the valve effect will be there, and the air will be shunted out, right? So this is a simple valve-like plastering technique for open wound on the chest wall, which otherwise might convert a simple pneumothorax into a tension pneumothorax. So the definitive management here would be to put a intercostal drain not through the site of the wound, but from another side, which is generally you will be taught how to use surface landmarks to insert IC drain. So you go in the fifth or fourth intercostal space in the mid-axillary line, or just anterior to the mid-axillary line. So that is the general landmarks for inserting an intercostal drainage tube. And definitely you will not go through the wound, right? You have to do it separately. Right. Okay. So following on, sorry about that. Yes. So here you see imprint aberrations on the hemithorax following trauma. So you find that this patient is finding it difficult to breathe. You see that the saturation is low. So what are the things that you should consider? Of fairly significant force, a blunt force acting on the chest wall, it gets transmitted to the very soft lung tissue, and it can cause flail segments or flail chest, or that is multiple rib fractures that are broken on both ends, and also it can cause underlying lung contusion. So the management is analgesia for pain because of fractured ribs, and some kind of ventilatory support or breathing support in the form of non-invasive, or you might have to actually intubate these patients and initiate intermittent positive pressure ventilation. Okay, but analgesia plays a great role in the management of these patients. So good analgesia, which could be in the form of systemic analgesics like opioids, or even regional anesthetics such as nerve blocks and serratus anterior plane blocks. Regional anesthesia is a very good solution for this kind of injury. And finally, this is our kind of best friend nowadays in emergency departments, that is point of care ultrasonography. All emergency physicians and people working in emergency departments are very proficient in using the ultrasound machine, because it is an aid. It's a clinical tool that we use to confirm our clinical suspicion. We answer simple questions, yes and no, binary answers is what we get from or confirm our clinical suspicion with the use of ultrasound. And this is a classic example of what is called subsified view of the heart, where you can see there's collapsing of the right ventricle due to a pericardial effusion. So this is what is known as the cardiac tamponade, right? So cardiac tamponade is another classic example of inflow obstructive shock. Okay, so because again, there is an impedance to the venous return onto the right side of the heart. So there is no outflow from the right side, which obviously means there won't be any outflow through the left side. So this is a classic example again of inflow obstructive shock, where the patient will be tachycardic, hypotensed. And if you look at the jugular venous veins, they'll be distended. You have JVP will be raised, or jugular venous distension with tachycardia and hypotension. This is the classic clinical signs of cardiac tamponade or an obstructive kind of shock. Okay, so what is the management? Management is obvious. You need to relieve the effusion in the pericardial through a pericardiocentesis. It's not as simple as it sounds. It's a highly skilled, complex procedure, but it is definitely a life-saving procedure. Right, so coming back to our case. So Palitha, he's 13 years, he's 40 kilos as assessed. He's crying, he's complaining of pain on the left side of the chest. He's got a respiratory rate of 40 with a saturation of 98 on some oxygen through a face mask. His capillary refill time is 3 seconds. His heart rate is 140 per minute. He's a blood pressure of 140/75 for a 13-year-old kid. Looks a bit strange. You can't see any catastrophic external hemorrhage, but he's got a bruise on the left hand forehead. So in your assessment, you assess that he does not have any catastrophic external hemorrhage. What about his airway? He's crying and he's complaining of pain. So that tells you that his airway is patent and he's conscious enough to complain of pain. But the problems are in your assessment of the breathing. He's got a respiratory rate of 40, which even for a kid of 13 years is a bit high. But then somebody might say it's because of the pain, but I would think otherwise. It's a bit of a worrying symptoms. Remember, respiratory rate is one of the most sensitive vital parameters that you can assess objectively, which tells you the gravity of the condition that you're dealing with. And the respiratory rate, which is high, is always something that you need to be very concerned about. He's saturating 98%, but that is with supplementary oxygen. So that doesn't really tell you that nothing is wrong with his breathing, but it just should flag to you that something is not quite right. Okay, so he's got a capillary refill time of 3 seconds, which is marginally raised. He's got a tachycardia of 140 per minute. For a 13-year-old kid who's just fallen, who's in pain, you might wonder whether this is normal, but I wouldn't think so. This is again another thing that should tick in your brain that something is not quite right. He's got a blood pressure of 140/75. And now this is a bit strange for a child of 13, but there again, it's the pain, it's the anxiety, it's the sympathetic stimulation, which is possibly driving up the blood pressure. But remember, sympathetics do play another role as a compensatory mechanism by causing peripheral vasoconstriction, which can drive up your diastolic blood pressure and narrow your pulse pressure. And that is one of the earlier signs of compensation for a state of hemorrhagic shock. So that is something that you should pick in your assessment. So that is why I always say these numbers have to be assessed very objectively, because they give a wealth of clinical information for you to focus on what could be wrong in this kid. Okay, and he's got a bruise on the left forehead. Now that should trigger that there could be some underlying traumatic brain injury as well. Okay, so these are the pertinent points that you would pick up in the initial assessment if you do it objectively, and you pick up many possible life-threatening problems in this kid who's fallen from a height. Right, so moving on. A little while into his arrival in your emergency department, he's becoming progressively more pale. He's complaining of more pain. And now his conscious level is changing. He's becoming confused. You find that the peripheries are getting cold and clammy. Now his saturation is dropping even. This becomes a bit thready. His heart rate has gone up to 155. His blood pressure has now fallen with a systolic blood pressure of 60 with a diastolic, which is not actually recordable. Okay, so things are not that great. Okay, and the capillary refill time has gone 6 seconds. So all this tells you that his cardiac output is compromised, right? He's not perfusing his brain. He's shutting down his peripheries. He's trying to kind of redirect his to the most vital organs, and even that is not doing that well. Okay, he's tachycardic, blood pressure dropping in spite. So this kid is pretty sick. Okay, right. Okay, so what are the problems that you think? Is his airway getting obstructed? It could be getting obstructed because his conscious level is changing, right? So that is something that you need to be concerned about. What about the problems in his breathing? Well, it could be a tension pneumothorax. He was complaining of a pain on one side. His blood pressure is dropping. He's tachycardic, and his saturation is not picking up with supplement. Could it be an open pneumothorax? No, there's no obvious wounds. Could it be a massive hemothorax? Yes, is a fall from a height, it could be a flail chest, and it could be underlying pulmonary contusions. What about his circulatory parameters, which are very concerning? It could be a cardiac tamponade. It could be a solid organ rupture. It could be a ruptured spleen. He could have retroperitoneal hemorrhage, which may go unnoticed. So these are some of the things that have to cross your mind when you're seeing these patients. What about his disability? Well, he's getting confused. He could be having a progressively worsening head injury. Could he be having some underlying spinal cord injury as well? Well, unlikely in this situation, but something that you might always consider when you're dealing with a patient who has fallen from a height. And always remember, in your in everything else, or the external part of his examination, hypothermia and hypoglycemia should not be missed. So you need to keep these patients warm, and you need to always check their capillary blood sugar. Okay, that is absolutely paramount. Okay, so coming back to Paedita again, we find that there are obviously again a confirmation that he has no obvious external hemorrhage. Yep, his trachea is midline and there is no stridor. Okay, his chest is clear, his air entry is normal, bilateral. Is tachycardic, his blood pressure is dropping, and his peripheral perfusion has got compromised. So he's definitely in what is called shock, when what is most likely to be hypervolumic, and because this is trauma, this is a hemorrhagic shock. Okay, so that should work up. You need to work those things simultaneously in your mind. Okay, he's slightly confused, but he's alert. Okay, his pupils are reactive and equal, and he does not have any focal neurology. Okay, his abdomen is tender on the left side, and he's got a large contused left flank, but there are no external fractures of the long bones. Okay, so if you put all these things together, you can work out what might be the problem that Paedita is having, considering the mechanism of injury. So it looks, so how do we intervene to Paedita? Okay, he has no catastrophic external hemorrhage, so there's nothing that you can do there. His airway is patent, but you want to be sure that you're going to stabilize his spine, cervical spine. So you can use inline stabilization with the help of a colleague, or you can apply sandbags onto each side. Because his breathing has compromised, you are going to give him supplementary oxygen. You're going to initiate 2 good functional large bore IV cannula. You're going to give the tranexamic acid. You might request for onic blood, and while that is coming, you might start on a bolus of crystalloids. Okay, and if the hypotension is not corrected, you have to look actively for possible concealed hemorrhage. And where do you look for concealed hemorrhage? In the body cavities, such as the pleural cavity, and of course the peritoneal cavity. Okay, and how do you do that? You can use the ultrasound at the bedside to identify both these concealed spaces, because you can actually identify pleural effusion, which is always blood until proven otherwise in trauma. And if you see free fluid in the abdomen, that is intra-abdominal bleed following a solid organ or a bowel damage. Okay, so these are the things that you have to think of, and you need to start following your assessment. You have to start treating these patients. So what are the possible solid organs, especially with a left flank bruise and pain in the lower left part of the hypochondrium region? You are thinking of liver rupture, it could be spleen rupture. So all of these need to be considered. Right. So diagnosis. So in Paedita, we find that we confirm that he's got a ruptured spleen and a multiple lacerated left kidney. So 2 solid organs that have got injured is what we find out following more extensive imaging. So what are the specific therapy options? Well, you can monitor this patient very carefully in intensive care. You can consider operative surgery. You might want to consider interventional radiology, or if you don't have any of these special facilities in your institution, you might want to consider transferring the patient once he's stable to a higher center. So these are some of the specific therapy options that you can consider for this young boy. Okay. Now, this is something, if you can't recall anything that I've told you over the last half an hour or so, please, this is something that I need all of you young interns to get very proficient in. And the lecture that preceded my talk was absolutely important, communication skills. And there's nothing more important as a young and budding clinician that you need to master at the onset of your clinical career, and that is communication skills, because that is so very essential when you're managing patients. Okay, you need to communicate with patient, you need to communicate with patients next of kin, but more importantly, you need to communicate with each other, right? And I'm sure at some point, I'm going to communicate with all of you guys and girls, right? You're going to call me up at the neurotrauma center and you're going to discuss about a patient that you have that you want me to help out in managing. But I need you to talk to me in this orderly, systematic way, because I need to get an objective assessment in my mind through your eyes. Okay. So remember, ATMISTA, when you're managing trauma, and ATMISTA is a simple mnemonic as to what you need to do. Okay. Now T is for time of injury. That's absolutely essential that you have that information at hand when you're communicating with somebody, right? And the mechanism of injury, such as fall from a height or a side impact or a pedestrian versus motorcycle. That is absolutely important, because that gives me that much of information to work out what are the life-threatening problems that I might be facing with this patient. Okay, so mechanism of injury. The moment you say the child fell off a tree onto a low-lying wall and then onto the floor, I think of the worst possible things. Traumatic brain injury, cervical spine injury, lung injury, solid organ damage in the abdomen, like all these things come into my mind. And then you need to be specific about the injuries that you found, okay, while you are assessing your patient, right? And what are the clinical features and what kind of investigations that you have initiated, okay? You need to be very objective about the signs, okay? And those are those objective signs that I mentioned, right? Such as respiratory rate, such as saturation, such as air entry and added sound, blood pressure, capillary refill time, heart rate, absolutely essential objective parameters that you should be available with to voice out when you're communicating with me. And then what is the treatment that you have initiated and how is that progressing? Okay, and it is it's systematic if you do it in a system approach, but if at all, you need to be very specific. Okay, and then what time do you think you can transfer this patient to the neurotrauma center? Okay, and what kind of requests of assistance do you actually want from me? Do you want me to kind of think that this patient, do you want me to do the CT first and then decide need to do? So you need to give me some inclination as to why you are contacting me at the neurotrauma center and why you want me to see this patient or to take on the management. Okay, you need to have some idea as to what I can do for you. Okay. And remember, especially when you're managing pediatrics, never forget the relatives, right? You need to keep the relations informed very objectively and honestly, and you need to kind of make them aware of the situation. That is absolutely essential, and I need to know that you have done that for this child. Okay, so this is kind of the simple approach and objective and a professional way that you need to communicate with your own colleagues when you are determining a patient with trauma who needs transfer or who needs some additional help from a fellow colleague. You need to conform to this mnemonic and this way of communicating. Right. Okay. So just to recap, life-threatening injuries where we assess and we treat exsanguinating external hemorrhage, inhalational injury, direct trauma, tension, open pneumothorax, hemothorax, flail chest, uncontrolled hemorrhage, and never forget this concealed hemorrhage in the chest, in the abdomen, in the pelvis, in the long bones. And remember, devastating hemorrhage in the subgaleal space in infants, because that is a large boggy area that can actually accumulate a large amount of blood. Okay, tamponade effects, so pneumothorax, pericardial tamponade, and burns can also cause hypovolemic shock. Okay, In the disability part, it could be a raised intracranial pressure, expanding bleed, or a spinal cord injury. And never forget hypothermia. Okay. So volume resuscitation with blood and blood products is absolutely essential, as I mentioned. Just to run through these things, as I think I may be kind of running out of time. But these are absolutely important aspects for you to consider. So remember tranexamic acid. So that is your dose, 15 milligrams per kilogram. You give this as a bolus, and then you can follow it up with an initial bolus over 10 minutes, and then the next same dose calculated that you can give over a period of 8 hours. So that's how we manage initial trauma patients with tranexamic acid. Normal saline 10 ml per kg is the bolus. You can follow it up with another 10 ml per kg until you get your blood and blood products ready, right? When you're resuscitating patients. Okay, so once you start blood and blood products, remember it's not just the red blood cell concentrate that we need to transfuse. Remember that these patients can become coagulopathic because they lose coagulation factors. So you have to make replacement of coagulation factors in the form of cryoprecipitated fresh frozen plasma. And remember, calcium is another important component on coagulation. So these are things that you need to consider when you're resuscitating hemorrhagic shock. And what is meant by a 1:1 ratio is that if you give 1 unit of blood, you have to give 1 unit of FFP to match, right? So that is the 1:1 ratio that you are going to follow. So it is really 1:1:1. Platelets also come into play. So if you are transfusing units, it has to be in that ratio. If you give 1 unit of blood, 1 unit of FFP, and 1 unit of platelet. So when I mean unit, calculation. Okay, so how you need to know how to calculate the requirement of blood. 15 ml per kg is for FFP, and for platelets, it's based on the units of platelets, which I'm sure you'll be able to learn once you start doing clinical practice. Okay, right. So here it is in more detail, right? Okay, so this final slide, I think, before my lecture ends, is something that is very important. Remember, when you're managing trauma patients, be it pediatrics, all this interplay is absolutely essential for you to have a favorable outcome, to drive down mortality and to reduce morbidity in your trauma patients, right? So you have to consider all of these factors, and the approach has to be systematic. And you have to pick the life-threatening emergencies early, and you need to fix the problem as assessment moves on. Okay, right. So I will now address the questions that you have posed to me on the chat box. And if you have any further questions, I'm very happy to take it. Okay, let me